Okay, it's 2 p.m. by my clock, so let's get started. Hello, everyone. On behalf of the SingHealth Duke-NUS Global Health Institute, I'm delighted to welcome you all to this webinar. Today's presentation is part of our Global Health Seminar Series, which are scheduled for every last Friday of the month at 2 p.m. We used to have these on face-to-face, but now we've gone in this online format, which is great because we can now accommodate many more people, and I'm really excited to see we have a lot of people in the audience. The goal of this series is really to engage our community across many range of different health topics, and we really kind of try to make sure that we get a good discussion going, that we have different perspectives reflected through the different seminar series. So it's great to kind of have this opportunity to share this with you. And today we'll be kind of hearing about innovative approaches in adapting technologies in low resource settings. We'll be looking at it specifically for the care of childhood surgical diseases, and presenting today is Dr. Amos Lowe, who is a pediatric surgeon at KK Women's and Children's Hospital. He subspecializes in pediatric surgical oncology and has a corresponding research interest in pediatric solid tumors. After discovering his love for surgery as an elective student in Kathmandu, he went on to train in general and pediatric surgery and was awarded the College of Surgeons Gold Medal in Pediatric Surgery in 2011. He further undertook an NMRC Research Training Fellowship at St. Jude's Children's Research Hospital in Memphis, Tennessee. He now leads the VIVA-KKH Pediatric Brain and Solid Tumor Program. This is a multidisciplinary collaboration that seeks to advance diagnostics and treatment for these diseases in Singapore and the region. He also co-chairs the Surgical ACP Global Surgery Program, which addresses the wide-ranging gaps in surgical care in low and middle-income countries in the region and looks at this through training and capacity-building initiatives. As you can tell, he has a lot of regional experience, and he's a very active member of the Global Health Institute, and we're really delighted to have him present to all of you today and to have him on our faculty. So before I hand over to him, a few housekeeping notes. Please keep yourself on mute during the presentation, although you have the opportunity to ask questions by typing them in the chat box after the presentation. And do know that the webinar will be recorded. So Amos, over to you.
Thank you very much, Amina. So thanks everyone for your time, and thanks to the SDGHI for this opportunity to share. So just over this next 40 minutes, I'll be talking on this topic of translating technology, right? So being able to bring across what we have enjoyed in first world settings to benefit patients in LMIC or low and middle income countries, and be focusing on areas in pediatric surgical diseases. Right, so let's get this off. Okay, so just something to start, a bit of a nugget from the very sadly missed Olympics from this year. So by way of an illustration, in professional swimming, when Olympic swimmers take to the water, they create this phenomenon known as a bow wave, right? And it's like what you get in front of a fast-moving ship. And because they're so fast, they create these waves in front of them. And that wave actually benefits the swimmer because they're so fast, they get up above that wave and they start to surf it. And that makes that fast swimmer even faster, right? So whereas for a slow swimmer like myself, right? So a disadvantage because we can't create, a bow wave like this, and then you don't have the advantage of surfing it. And so a slow swimmer then becomes even slower, right? So just follow me on this analogy. But in contrast, in open water swimming, without the lane dividers, the lead swimmer creates bow waves that then spreads out on either side. And very much like how a flock of migrating birds travel together, a slow swimmer, if positioned correctly, can actually benefit from that bow wave and surf that and actually pick up speed and catch up with the leader. So I use this as an analogy to talk about how technology then impacts healthcare, and particularly in a discipline like surgery. where we're very reliant and on the benefits that technological advancements bring to us, right? And also then moving forwards, how this can be used and capitalized to help people leapfrog forwards. Okay, so I'm gonna give a bit of a background into this topic, and then I'm gonna cover in two broad areas. First, the dimension of the use of this in diagnostics, in conditions that we're used to treating, and as well as in therapy and treatment. So first of all, in terms of background, technological capabilities are something that are familiar to us as surgeons, and these are enablers for healthcare advancement. A very simple example here of endoscopy, when this was first conceived, it relied on an understanding of optics, right? But although in a very primitive manner, and I'm very glad that we don't have to do endoscopy like this, as you see on the left, right? Like a sword swallower. But that gives rise, even in its most primitive form, to an increase in knowledge with the early promulgation of that knowledge, and that then builds one step upon another to innovation of flexible endoscopies. I'm also thankful we don't have to do endoscopy like this today, to then what we have in our present time, right? This then, if we think about it, pans out in many other dimensions, such as in something very tangible to us right now in the midst of our pandemic. And we're very thankful for the advancement in knowledge that vaccines gave to us, right, long time ago, to now benefit present day. And again, those who have that technological advantage then leapfrog forwards and move faster in current situations. Now, another point about this is that this is not a linear progression, and much data has shown us that basically technological enabled progress in healthcare is one that builds exponentially upon prior developments. And this has been seen in areas such as DNA testing and in the use of genome sequencing in recent times, right? So this is something that is in a logarithmic scale when we think about that in terms of progress. The other aspect of this on the flip side also is then that when access to healthcare is not available, that then widens gaps in not just socioeconomic dimensions, but also in terms of health outcomes. And it's something that impacts very broadly, not just in terms of access to these advancements, but also then it has ramifications in terms of increasing the gap in terms of healthcare professionals' capabilities, in terms of the regulatory standards, ethics, practice that then starts to widen more and more as this lack of access to technology widens. Now, question that I would pose here is that then can this stepwise development of healthcare capabilities be potentially leapfrogged for what would be a first world country journey through process of development, building on that stepwise increase? Can an emerging economy or an emerging country setting possibly leapfrog that? And this is an example, for example, in molecular diagnostics, right? Jumping forwards in terms of using new technologies instead of going through the process of developing standard clinical assays, right? So we think about this then in context of the challenges that are posed mainly to non-communicable diseases in LMICs. And I put it to us that there are two key areas that are real gaps in terms of addressing the needs of non-communicable diseases in LMICs, and that's in the area of diagnosis and treatment. And I'll cover both of these later in terms of how we've tried to think about addressing these in LMIC settings. Furthermore, I like to also say that I think some of the blind spots in LMIC health policies and systems center around surgical or intervention type diseases, as well as in underprivileged or sideline populations, particularly in children, right? Because a lot of their attention then goes to adults and those who contribute actively to the economy. When we look specifically at childhood surgical diseases in LMICs, two main areas stand out, and that is in the area of congenital abnormalities and deformities, and the other in the area of neoplastic diseases. And so when we look at the chart here on the left in terms of unmet needs across a variety of third world countries, we see that these two categories, which are the middle two in this chart, dominate the percentage of unmet needs in LMICs in the area of childhood surgical diseases. Now, another thing to talk about is the context in which we immediately operate. And Southeast Asia is a unique area because of the rapidly emerging economies. And these not only present a widening gap in terms of the wealth gap in ASEAN and Southeast Asian countries, but also there is an ongoing, very interesting dynamic in some countries where there is where there's a very rapid speed of catching up. And this is manifested also in direct areas like healthcare expenditure, where we've seen that rapidly increase in recent years. And so when we think about translating technologies and applications into LMICs in our region, we have to think about that as a moving goal, somewhat different from other regions in the world, where we think of very static type of situations in their economies. Let's move into this first area of diagnostics. And so I want to focus specifically on the area of neoplastic diseases and cancer. This, of course, is an area of interest of mine, but something where diagnostics plays a particular role, right? And so in childhood cancer, these, while rare, when we flip the frame of reference and look at that in terms of potential person years that are saved, these are second only to breast cancers and across the whole of the United States. In contrast to some other adult cancers that perhaps may be present more in elderly patients or with a lower potential lifespan that can be saved. The other aspect is that this outcome is very significantly different in LMIC versus high-income country regions. And so when we look at that across different areas and continents across the world, as you see on the chart on the right, we find that in Asia, we are second only to Africa in terms of the mortality from childhood cancers in comparison to the West. Now, so we asked ourselves this question, and in a recent study done by actually one of our recent fellows, we looked at this question about what are some of the gaps in terms of pediatric cancer, particularly pediatric tumor care in our region. This was a survey-based study where we looked across at multiple pediatric solid tumor and brain tumor centers across Southeast Asia. And we found that there was a large discrepancy in terms of the level of expertise that was available in these centers. And particularly one element stood out, and that is the percentage of these centers with multidisciplinary tumor boards. Now, it appears that in tumor care, we require a multidisciplinary group to work together, and this is clearly lacking in centers where key expertise is missing. And when we profile that across each of the countries and each of the specialties, we find that while many of them have oncologists and surgeons, many of the other disciplines were missing from many of these countries, and that seemed to correspond also with the GNI, or the gross national income per capita, in each of these countries. One of the areas I want to focus on is this lack of pathology diagnostics, right? And so when we look at that in terms of a gap analysis in these centers, indeed we found that pathology and radiology were among the areas that impacted them negatively the most, right? And so taking this forwards, we are interested to ask ourselves the question, what can we do to address this, right? So in one area I want to address first, and that is in WILMS tumor, which is the commonest renal tumor in children. This has evolved in recent times to focus on molecular prognostic markers, one of them being loss of heterozygosity in 1p and 16q. studies in North America have shown that these basically portend a worse prognosis, and these children may benefit from enhanced chemotherapeutic regimens. But if you can first identify that they have this molecular prognostic marker. However, when we look at that in our local populations, we find that there are significant differences. Somehow our Asian patients seem to have disproportionately superior outcomes. And so we ask ourselves that question, is this still relevant? However, the problem is that the current assay developed in North America requires frozen tissue. And when we want to try and expand that across populations in Southeast Asia, in many LMICs, this is not available. So we undertook this project, and this was done by our staff in our lab, as well as one of our students who now is enrolled with Duke. We had him when he was an undergraduate. We looked at this question of whether we could optimize this assay for formalin-fixed specimens, right, and thereby making this available to people in countries without frozen specimens. So looking in about 80 cases of renal tumors that we managed at KK, we then optimized these assays based on specimen age and based on the primer design and the primer product size, and were able to optimize a workflow for these specimens, and then use that forwards to profile 1P and 16Q loss of heterozygosity across a panel of Asian patients in our series, right? And using this, then we compared across multiple other groups, and we were able to conclude basically that, interestingly, the incidence of loss of heterozygosity was similar in Asian patients as compared to other countries, which then led us to ask the question, perhaps are other loci more relevant for prognostication? But this would then require further study. But now, having optimized this assay, it was now possible to study specimens across a broader number of LMIC settings where frozen tissue would not be available, but when we could now tap into the rich resource of formalin-fixed tissues in these other settings, right? So we've then taken this forwards to a next generation of LOH profiling for WILMS tumor. This is supported by an SDGHI Global Health Support pilot research grant in a new multiplex assay, able to cover more targets, as you could see, and is already seeing increased international adoption. Interestingly, we found through a collaborator in Vietnam, Dr. Bao, who runs a genomics lab in Ho Chi Minh City, that this same MLPA platform was already in use there for other copy number type testing. Only requires a thermocycler and capillary electrophoresis systems. And so this was already readily available in Ho Chi Minh City. This presented then an opportunity for research collaboration where we could advance the questions about interethnic variations in WILMS tumor, as well as an opportunity to build clinical capacity because their assays had not been cross-validated with other laboratories. And so this study now is then exploring this aspect as well of capacity transfer. Move on to another area and another disease group, which is pediatric sarcomas, and particularly the place of gene fusions in these tumors. So in pediatric sarcomas, unlike many adult cancers, they are actually fairly quiet mutationally. However, they are characterized by characteristic gene fusions, which increasingly are being discovered, right? So as we are moving along, even in a first world setting, we are increasingly being challenged to identify more and more of these previously unknown cancers based on new gene fusions that are molecular signatures that we can identify. So that's even a challenge for us in a first world setting, much less if we think about it in an LMIC setting. This is very much the work of Prof. Kenneth Chang and our group in the VIVA-KKH Pediatric Brain and Solid Tumor Program. And so I draw from some of these examples that he's shared. Now, this is an illustration of what is the typical workflow as we approach a challenging cancer, right? And this is an example of that. Following surgical biopsy, we have the formalin-fixed specimens done, slides cut, morphology analyzed first, then immunostaining, and before molecular testing then takes place, right? And this can be a long drawn-out process with much cost involved. Now, the question we ask, coming back to our leapfrogging example at the beginning of the talk, is if we can use molecular diagnostics, can we skip many of these steps to perhaps back validate later on and also save on cost? Problem again, as we saw with the WILMS tumor example, is that many of these are resources that are only available in first world settings and work only on tissue specimens that can be prepared in the first world setting. So as we looked across at the menu of clinical assays that we have in terms of molecular diagnostics, we also identified through our program new technologies that could be faster, of lower cost, albeit performed in a more advanced research lab, but could work on formalin-fixed tissues that would be available in third world settings. And so the first of these was a sarcoma fusion assay that Dr. Kenneth Chang and his group developed, covering over 170 fusion variants in that first version, covering over 28 sarcoma types. And so over a turnaround time of what is perhaps about 48 to 72 hours, we can, in a single assay, search for close to 200 of these common sarcoma fusions in order to identify these large variety of pediatric sarcomas and rare sarcomas using a single test. And the other was another assay called the Archer Fusion Plex Sarcoma assay, and this one involves a sequencing approach to identify novel fusion partners based on a bioinformatics approach, right? And again, both of them working off of formalin-fixed tissues. So here's an example of one of these cases that came, a 15-year-old who came from a regional country with an original diagnosis of atypical osteosarcoma. Now, only one small formalin-fixed block of post-treatment material is available. Pathologists there couldn't make a diagnosis, very necrotic tissue, and so that was sent across for work on the platform. The patient subsequently presented with lung metastases. There was questionable morphology here because osteoid was not clearly seen. There was some weak patchy CD99 staining, and the features were neither good for osteo or the differential, which is Ewing sarcoma. And so using the nanostring assay, this was diagnosed as a B-core CCNB3 sarcoma. This is a novel entity, now recently reclassified as an atypical Ewing sarcoma. Recent molecular profiling suggests this is likely a completely separate sarcoma entity. This then, with gave rise to a research study, right? Then with a group from Southeast China, with Dr. Chang's pathology group, then described these sarcomas with B-core CCNB3 fusion, and this is then given rise through the network with the St. Jude VIVA group to more collaborations with the group in China to pursue this area of investigation. So this has been possible because of a multidisciplinary collaborative group that was set up some years ago now, the Pediatric Brain and Solid Tumor Program, with support from the VIVA Foundation and St. Jude Children's Research Hospital, and brought together multiple ACPs at institutions from our cluster with Duke-NUS together into a collaborative program. This was a multi-pronged effort, then focusing on multidisciplinary clinical care, translational research, data, and population-based science, as well as education, exchange, and collaboration. Since then, in particular, the diagnostics arm has gone on to launch these two as validated clinical tests, which have now benefited multiple patients across different local and regional centers. The diagnostics arm has gone on to produce its share of academic results, as well as education initiatives, right? So as we think about how we can benefit regional patients, it's not just through bringing specimens in to test, but also train, right? So one of these flagship events, the St. Jude Viva Forum, has been complemented with subspecialty programs in pathology. This began in 2018, training pathologists from regional countries, and has gone on also to cover other unmet needs, right? Other specialties in pediatric surgery, as well as in nursing, in collaboration with our partners in NUH and other hospitals in Singapore. Right. Let's move on to the other topic about therapeutics, right? So we think about how can we take advantage of some of these technological advancements, but adapt them appropriately so that we can benefit patients in LMIC settings in a similar way. So I think one thing, you know, growing up in SingHealth and in KK, I tremendously appreciative and respectful for the rich legacy of regional humanitarian outreach that characterizes so much of the work that takes place and growing up in the system. You know, we've become used to seeing that as part and parcel of our duty of care as doctors and as surgeons. This has been work led by many of our senior professors before us in many of our regional countries, and bringing surgical outreach to many of these centers. This dates back to the 90s, so with almost 25 to 30 years of work in a multitude of regional centers, although primarily centered around humanitarian outreach. And so that leads us to think about this question in the light of our new knowledge about global health and global medicine. How do we move beyond just caring for single patients at a time towards enabling and in a more false multiplier effect to benefit and transform healthcare in these diseases in our region. And so at this period of time, a recent landmark work by the Lancet Commission in Global Surgery, it has really brought us the truth about the global burden of surgical disease. And that's not something that is small. Furthermore, we've come to understand with more data coming out from this effort that actually the needs in terms of surgery are even more pronounced, particularly for children. And in the abstract for the talk, I was sharing that up to 85% of children requiring surgical attention in LMICs are presently not getting that care. And so one particular aspect that we think about is in laparoscopic surgery. And this is something that we've taken for granted very much in our settings. In our surgical training, we've gotten used to laparoscopy as the go-to standard for many surgical procedures like appendicectomies as well as cholecystectomies. However, as we looked across to other settings, for example, in Africa, we realized that this is really something that is not the standard at all. These are pictures from our one of our collaborators in Duke, Tamara Fitzgerald, and you can see the operating conditions within some of these centers without reliable power source, without proper infrastructure. Performing surgery by the light of your mobile phone is certainly not something that is ideal. And then to take that leap and say that in such a setting, how can we bring the benefits of minimally invasive surgery? How can we possibly bring that to a setting like this where even basic healthcare needs are not even available? Right. And so in a recent study that we just published last month, we looked at this issue of laparoscopic experience and attitudes towards the idea of laparoscopic surgery and a low-cost option among surgeons in Africa, right? So surveying a group of 56 surgeons across Central and Eastern African nations, we saw that there was very much a lack of access to good equipment, and cost being one of the main barriers to this. So in also looking at their qualitative reports from this, there is certainly a need for it. And with the world shrinking in terms of awareness of what's available out there, many of their patients were aware of the possibility to have their surgeries done in a minimally invasive fashion. They were aware of the benefits of not having a big, painful incision, but many of the surgeons were unable to deliver this because of the resource limitation and the cost and maintenance of these equipment. So we set about trying to address this issue of low-cost laparoscopy. So for the non-surgeons in the audience, let me just pause a minute and give a bit of an overview. When we perform a keyhole or minimally invasive surgery, there are several components that are required, and I illustrate that here. First, a camera is needed, right? And present, I've listed here what our current standards are, and I'll talk us through some of the substitutes that we are looking at. So first of all, a camera is required. Typically, it uses a high fidelity optical CCD to capture that. Lighting, which you can see illustrated in the cartoon here, typically provided by a fiber optic cable. Gas insufflation when we perform laparoscopy here to create pneumoperitoneum, and that requires a carbon dioxide supply. Then in the context of an abdomen where there may be soilage from infection or bleeding, suction and irrigation is required, which are then piped through our central medical vacuum systems, which we're used to finding on the walls of our operating theaters. Now, many of these resources are essentially not available to begin with, even in our in a third world type setting. And so we looked at possible options to replace some of these, perhaps with compact CCD and LED units, which you find on the back of your mobile phone, replacing gas insufflation with mechanical retraction, and replacing things like medical vacuum with pneumatic systems. And so with this other funded project through the Duke-NUS research collaboration program, we have assembled a team from the group in Duke in Durham, as well as here in KK, as well as colleagues and partners in Uganda, to look into this issue of increasing accessibility of laparoscopic surgery in LMICs, right? So fundamental to this were prototypes that were developed along with the engineers in Duke, and that now we are testing, and these include a low-cost laparoscope that can be powered and visualized using USB, and a sterilizable but equivalent low-cost LED CCD device to facilitate laparoscopy using a low-cost system. Next was also a unit to replace gas insufflation, and this was a laparoscopic retractor to create space in the abdominal cavities to allow and facilitate laparoscopy. In addition to that, so my department colleague, Dr. Diok Tien, along with our surgical colleague, Wong Ting Hui, who many of us are familiar with as well, have been looking into complementary systems, right? Like, so this one being a standalone laparoscopic suction irrigation system, which can be powered using pneumatic systems without the need for medical vacuum, right? So then put together these what we see as potentially a suite of low-cost laparoscopic devices that can be deployed and reach that tier of the market that is in need of low-cost equipment without the need for advanced medical support in order to perform simple laparoscopy at least for visualization, triaging of abdominal conditions in regional type healthcare settings. So I want to talk about this in a bit more of a holistic sense, and that is not just in developing the devices, but we recognize a need for a complete approach to this in terms of developing systems, partnerships, as well as training. And so coming out of this in 2018, led by Prof. Tan Yang Kun, Surgery ACP did a visit with the Duke University Medical Center, and across multiple tracks built up a series of collaborations with the Division of Surgery in Duke. And key to this visit were significant people that we got to meet, right? And this was the beginning of what was a very important and exciting collaboration on multiple fronts. Prof. Mike Merson, who's recently handed over to Prof. Tan, the leadership of the SDGHI, and Tamara, who has now become a close collaborator and a pediatric surgeon herself in this area. And so with that, in the Surgery ACP, we've recently established this global surgery program with the aim of consolidating efforts across SingHealth cluster to look at a holistic way to train surgeons in our region to build capacity and to build up this regional network of collaborations, right? And this is centered around 3 dimensions of training, visits, clinical fellowships, and regional capacity building workshops. Multiple institutions across the cluster and different departments have seeded this first lot of efforts in a series of countries going from Myanmar, Sri Lanka, Indonesia to Papua New Guinea. All right, and so at least on the global pediatric surgery front, how has this manifested? So riding on what we've been used to, which are very much humanitarian outreach type settings, this has carried on in the form of education and training visits. Here with my colleagues, Dr. Lo Yi, Dr. Rambarai, in these pictures with our collaborators in Port Moresby General Hospital in Papua New Guinea. So our lady surgeons are very brave in this not very safe environment in Papua New Guinea, but conducting education as well as operating with the surgeons whom themselves have previously trained with us in the department. Right. Exchange fellowship program has accompanied this. So in the area of surgical oncology, in general pediatric surgery as well, facilitating the opportunities for regional surgeons to come and spend time training and learning with us here. And of course, in this last year, with the disruption of the COVID-19 pandemic, much as this has driven us online. And so our colleagues have taken this in stride to bring many of these regional discussions and case consultations online instead. Right. And so I close off the talk here with a summary of a couple of wrap-up points. The first that I hope I've convinced you is that technological capabilities are indeed a force multiplier for healthcare advancement. We feel that particularly in the area of diagnosis, especially with advent of molecular diagnostics, and in the area of treatment, especially in the use of technology-dependent resources such as laparoscopy. The second is that despite having gone through a very stepwise capacity building journey, especially in the West and in current first world countries, this process is something that perhaps we suggest can be leapfrogged on both these aspects in terms of diagnostics as well as therapeutics by strategically adapting technology and adapting methods to be able to comply and be applicable to restrictions and limitations in low and middle income countries. And the third thing is that really a holistic approach is needed, addressing not just these aspects of technological advancement, which sometimes is easy to get wrapped up in, but also thinking about human factors, thinking about health systems and resources, adapting these into local settings so that they can be effectively employed. And the last being that we mustn't forget that technological advancement is something that is a dynamic process. In as much as our cell phones have shrunk in size significantly over the years, and so have our personal electronic devices, we can expect that in our years ahead, we will continue to see these advancements, and we will continue to see these impact healthcare in a similar manner. And so this is an ongoing process that needs adaptation towards evolving technological progress. Okay, and that's it. I'll wrap up here. Thank you very much. We'll take some questions now.
Yeah, thanks a lot, Amos. That was a wealth of information. So I think you've really covered a lot of different topics. So we'll see. I think there were some questions that came in from when people registered, and Muriel is going to post them in the chat. So we can start with those. But in the meantime, I do encourage people to write any questions they have in the chat group. And I think I have a couple of questions, but I'll wait to kind of see what our audience has first. So can you see the chat, or do you want me to read it out to you?
Yes, I can see the chat.
Okay.
So we'll work our way through the questions, and certainly we welcome any other thoughts along the way. The first, and I'll read it out for everyone. The first is there value in intraoperative telemedicine to guide doctors in difficult surgeries? My personal opinion on this is that I think that this is unfortunately something that is perhaps more easily said than done. And I think my honest answer is that I think there are very real restrictions towards implementing telemedicine in surgery. For the longest time, this has been purported, and in multiple presentations, we have all seen these ideas being put up. However, I think there is certain dynamics in surgery that cannot be replaced through a video screen, right? These are a sense of the multifactorial processes that are going on in the operating room with the anesthetist, with the other members of the surgical team, and very critically also is the tactile feel that is required in these surgeries. So some may argue, how about things like robotic surgery or where you do not need the touch and feel? Then I think itself, in a way, it's a self-defeating answer, because in a context like that, then one might argue that if you already have the capability to perform advanced surgeries using systems like that, then likely telemedicine coaching is not going to be required. Okay, so the second question is, what are necessary tools needed to treat these patients you're referring to? And here, this would refer to our children with surgical conditions, and how do we shorten that gap? So I hope I've tried to answer some of these in the talk. And my summary answer here would be that I think in the area of treating these conditions, as what we saw, perhaps the two most common ones being that of congenital abnormalities and neoplastic diseases, that the area of diagnostics and advancing the accurate diagnosis of these patients is the first important element. The second being that how can we bring the advantage of first world surgical systems. In this case, I think the most acute one being in the area of minimally invasive surgery, and adapting that, right, to these patients, right? But shortening that gap, I think, is something that is not just about bringing first world equipment and donating that into third world settings, right? And in many contexts, very sadly, in our trips, you know, we've seen stockpiles of donated first world equipment collecting in the back halls of operating rooms and storerooms that have either broken down and with no support to maintain or repair, or with the local surgeons not having the expertise to use them. So I think each of these need to be adapted in, but we also want to try and work dynamically, I think, with the surgeons and the doctors in these settings to try and move them up the ladder. I think in the same way that if we see ourselves 5 years down the road, and we ask where we are with some of our partners, and they're really at the same place where they were 5 or 10 years ago, and we are still going in doing the same trips, doing the same surgeries or doing the same procedures alongside them, then somewhere along that chain, I think we have fallen short in terms of that capacity building and enhancement that should have accompanied these programs along the way. Okay, the third question here is, what is the training plan for LMIC pediatric surgeons? I think to answer this question, I could share from, I think, the experience from our department, and I think greatest challenge that we face in terms of training for our colleagues from LMIC settings is being able to train in a relevant fashion. And I say that because oftentimes I think I'm concerned that our colleagues come and they spend time with us, but I'm very concerned that they go away learning things that may not be applicable or may not be relevant in their settings. Now that's $1 million question. I think that's really hard to answer, because if the training plan or the training curriculum does not teach a training pediatric fellow anything more than they already know, then that compromises the value of their training fellowship. Yet at the same time, if that training brings to them things that are too far off, then that also is irrelevant. I think that there is always a need to push and stretch a trainee or a fellow to a limited extent, such that they are inspired to take something back and to bring their systems forward a step. One of our recent fellows, parodied the slogan of Air Asia, where it says, now everybody can fly. And he said that, after I've trained, now I think everybody can do laparoscopic surgery, right? And the idea being that I think the training of a fellow from an LMIC needs to give just enough tools to help them bring back that new method, that new technology, that new approach, adapt it back into their local setting, and then start to innovate on their own and bring that forward another step.
So while we're waiting for maybe other questions to come in, actually, I'll just pick up on that point, because certainly this whole thing of, at what level or what point is the training just right, when it's not too dumbed down that I already know this, and when it's not too complex that I can't apply it. I think the other question I had in your summary, maybe it was at point 3, it's what's the health system that they are operating when they go back, what does that whole system look like? And also maybe, at least us from an institutional point of view, we think about how can we engage not just with the particular trainees, but with that whole environment that they're situated in, and how can we maybe maybe work with them and strengthen it and, kind of collaborate in all kinds of ways so that when someone goes back with this training in hand, they feel supported and enabled to do that. So I think that's really an important point to kind of keep in point. We should talk more about, what is happening and how SDGHI can support that, because that's really one of the things that we feel very strongly about, that the training should be contextualized, not just in the training program, content itself, but in the going back and the whole infrastructure around the people, so that you connect with not individuals, but you connect with, at an institutional level also, and there's long-term follow-up. So I just wanted to kind of follow up on that point. And we do have another question, but I just do want to also add one more comment, because that really rang a bell when you talked about, and you show the slide of which are some of the blind spots. So NCDs in general, sometimes in low resource settings, get a little bit less attention. And then for children in cancer and surgical diseases, it seems to be particularly, a blind spot. And we had an interesting experience of, actually, we were trying to set up a project with Duke, faculty from Duke who works in Tanzania on children's cancer. And it was just we just needed a little bit of support from the in-country actors to get more data. And we reached out to UNICEF, which is a wonderful organization, of course, totally focused on children, does amazing work. But when we approached them with this, they said, oh, but we focus on diarrheal disease and water. They just didn't see the reason that they would engage in it. Whereas like when you showed, it's actually a large percentage of what's, kind of affecting children. So there is a lot of, I think, even international level kind of attention and kind of discussion that what are some of the pain points that we need to bring to light and, have them more supported. But I'll keep quiet now because we have another question.
Yeah, so Amina, maybe let me just make a comment on that. And I think that's a relevant thought. In the same paradigm and the same context as we talked about evolving and changing advances in the field of technology. And the same thing happens, I think, with healthcare needs, because oftentimes I think we may get stuck in a frame where we think about the important needs of a regional LMIC country or setting and get fixated in that. And we are talking about, communicable diseases, and we're talking about clean water. And I acknowledge that these are problems that persist, but we may then blindside ourselves to the fact that non-communicable diseases may be creeping up that ladder as these economies are evolving and emerging themselves. And 5 years, 10 years, 15 years will go by, and we're still stuck in that frame, thinking that they are still back there. Yeah. Yeah, maybe we go on to the other two questions that are posted on the chat. Okay, so there's a question here with regards to number 2. Have you seen any engineering or developing progress of diagnostic devices specifically for LMIC? And the lack of resources is the biggest problem. Yeah, I think I can make a comment to this, and this is something that for myself, I've learned a lot from my senior colleague, Professor Annette Jacobson, and so in her decades of work with regional countries, clearly the partners that have come along the way have been more than just healthcare people from the healthcare sector, but foundations and groups that work with other aspects, right, like clean water and housing. And I think it's been enlightening for me when speaking to some of them that there are people who appreciate and understand these aspects outside of our usual frame of reference. And specifically with regards to device, I think, and that we can make available to LMICs, I think these need quite a rethink and really will benefit from strategic partners that I think share that similar vision. For example, as we think about clean water as an issue, we have our solutions for that here in Singapore, right? We've got new water. We think about filtration membranes, but the truth is that not all of these are practicable in an LMIC setting, and instead, we need to be thinking about lower cost, more easily promulgatable resources that can be really implemented in these settings. And so I think the same applies when it comes to medical devices, because really what we have is a market that's dominated by for-profit type companies, right? Certainly these are for first world gold standard diagnostic and treatment devices, right? And I'm not saying that this should change, but we cannot just take that wholesale, I think, and expect to implement that into LMIC settings and along the whole chain, because in terms of manufacturing, in terms of licensing, in terms of safety accreditation, we may need to rethink this from the perspective of an LMIC setting. Trying to balance out against the other dynamic, which is also that we cannot take this as just a test bed, right? And be careless with safety considerations in these settings. But can we think about, you know, medical device development in the lower cost market, right? In the same way that people have thought about that for digital devices. Not everybody needs to own a Samsung or an iPhone, right? If you can create these devices at a fraction of the cost, perhaps not with the same kind of functionality, there's a huge market that is in need for such devices. And again, that supply chain and that manufacturing and that licensing will be entirely different from what Apple or Samsung would have.
Well, I'll say I'm a proud owner of a under $200 phone, and it does me very good. But seriously, so the thing that was going through my mind when you were presenting your many different scenarios, and it kind of relates back to this: how do we ensure or encourage or just work with the communities that we are kind of engaging with? So I think to your point of what I think they would be best placed, and there's certainly a lot of creativity and innovation capabilities that exist in these different countries across ASEAN and globally. So I think that's another thing that for us kind of as researchers and implementers of certain kind of technologies, it's not, the locus doesn't sit just in Singapore, in the US and UK or whatever. I think the locus for innovation and creation sits very much in the regions also, and maybe it's our collaboration and engagement with them that we need to, kind of just like strike a match so maybe if you've had any experience of that or think of ways.
Yeah, I think your point is right, and that engagement to properly understand the felt need on the ground is very important. I think that's something we learned from the the experiences we've shared with the group in Duke and in Uganda, and likewise talking to some of our foundations and engineering collaborators in the region. This understanding that there must be a buy-in, and it's a partnership with the LMIC partner as well. Thus, for example, when we were talking specifically about low-cost laparoscopic devices, one very key response that we got early on in the discussion was they were saying that, this can't be free. This cannot be a free resource. This has to be something that there is an exchange. This is something that, yes, is priced into a low-cost market, but it's something that is purchased. And then you manufacture it to meet that purchase price, that price point. Because then there is buy-in, and because that buy-in then creates a commitment towards that. A free phone, okay, although we know that then there's no such thing as a free phone, but a free gift versus something that we would acquire with our savings is something that we would treat very differently, right? So I think the same applies when we think about that.
Absolutely. I think there's one last question and we probably have time just to take that and then we'll wrap up.
Yeah, okay, so question here on, in addition to research and medical devices, simple issues like infection control are equally important. Yeah, I agree. So this, I must say, is outside the scope of what we are doing, but I clearly see that there is a need there. If we think about sterilization systems, when I come across from that from a surgical perspective, we do have fairly elaborate sterilization systems that are gold standards in our settings here, but these are certainly things that we can't port over into LMIC type setting. At the same time, what they have there is not always practices that should be, encouraged to continue. I remember years ago as a surgical elective student, operating in the operating rooms in Nepal, we will wash, surgical gloves, dry them out, right, and then powder and put them back on again after that. And some of those practices continue till today. But it's not right for us going into settings like that to endorse practices like that, saying that, oh, you know what, there's really nothing better that we can fit to it. So, just carry on doing this. I think the way to go about that, like what you suggested in your question, is to think about innovative ways to look at sterilization, chemical sterilization, or other kind of sterilization that can then be itself a force multiplier to allow for better surgical care, reduce wound site infections in these settings.
Okay, so well, we know that these are very complex questions, and even solving the technology bit of it is just one little aspect of it, and it's situated in this whole host of other issues. But we'll all work towards a common goal. And I see it's exactly 3:00, so we'll wrap up. Just want to say thank you very much, Amos, for kind of giving this really kind of in-depth presentation of your work. Really interesting. I knew most of it, but not all of it. So it was great for me to learn that too. Thank you all to the audience. Hope you guys enjoyed that, listening to this. If you have any questions, just send it to us and we'll, try to get it addressed. We'll have this on tape on our website. So, if anyone who missed it or someone who wants to will be there. And see you again next month, the last Friday of the month. Look out for our things. Thank you, everyone. Bye-bye.